In this video, we're going to take a look at open evidence. That's a research tool that helps hormone optimization providers and functional medicine clinicians find and understand studies faster without spending hours buried in PubMed. If you're a hormone doctor or BHRT provider, you already know that PubMed is full of valuable data, but it's also maybe a little bit slow and hard to translate into clear patient education. For years, I've relied on PubMed myself, and then I started using ChatGPT to summarize research, and that helped. But sometimes ChatGPT hallucinates. It basically makes up studies out of thin air, citations that don't actually exist. And that is a major problem. I've caught ChatGPT doing that several times in my research. Open evidence solves that hallucination problem. It gives me the speed and the clarity of AI tools like ChatGPT or Gemini or Perplexity, but everything open evidence retrieves comes directly from PubMed indexed research. I'm talking about real studies, real citations, no hallucinations. I'm Steve Goldring, the Hormone Pharmacist. I help hormone optimization providers streamline their practices, save time, and simplify their patient education process. If you'd like to connect with more hormone patients, visit simplehormones.com/database to apply for a listing on my hormone provider database. That's a directory I use to send patients to providers just like you. Now let's talk about what makes open evidence such an effective tool. Think of open evidence as a bridge between PubMed and maybe AI. When you ask open evidence a question, like let's say, progesterone and sleep quality after menopause. It searches PubMed, Medline, PubMed Central, and then it summarizes the key studies with citations that you can verify just by clicking on them. That's what separates it from general AI tools. It doesn't guess, it verifies. For those of us who practice hormone optimization or functional medicine, open evidence helps to translate that research on things like estradiol and progesterone and testosterone and thyroid into language that our patients can really understand. There's a big advantage for any hormone provider who values clarity and credibility. Here's a question for you. Do you use open evidence or other AI research tools in your practice? I'd love to hear from you. Leave a comment and let me know what's working for you and what's not working for you. So let's take a look at how open evidence works and where maybe its limitations come in. First of all, it's free. If you're a licensed provider with an NPI number, you can sign up at openevidence.com. Open Evidence searches only PubMed index literature, so it doesn't look at every journal or every website, and that means it might miss a few newer studies, maybe some paywalled publications or research that's in other fields, maybe sleep medicine or neurology that might not be indexed in PubMed. Open evidence also favors large clinical trials and meta-analyses. Smaller trials or preventive studies might get buried in the literature. So while it's powerful, it's not perfect. Think of open evidence as a fast, reliable research assistant that occasionally is going to miss something, some nuances. Here's why it's still a game changer for hormone optimization providers. Speed. It distills dozens of studies in a matter of seconds. Clarity. The summaries are pretty readable. They're organized by outcomes and mechanisms and dosages. Confidence. You can reference real citations in just about every conversation. That combination makes open evidence perfect for consults and presentations or patient education. That's how I use it. Patients might not really care about the studies themselves, but they trust that you understand them, and that builds their confidence in your abilities. So even with those strengths, open evidence does reflect the same sort of biases as the medical literature itself has. First of all, let's look at volume bias. If we consider drug-based interventions, they dominate the literature because there's more studies. Second, guideline inertia. After the WHI, there's a lot of caution about menopause hormone optimization, even decades later. Third, endpoint bias. It favors hard outcomes like fractures or mortality over mechanistic prevention. Fourth is specialty bias. There are certain, let's say, great hormone research in neurology, sleep medicine, orthopedics that might fly under the PubMed radar. The takeaway is that open evidence is accurate, but the playing field isn't exactly level. And here's how I handle that. If open evidence says something like, let's say, oral estradiol increases the risk of blood clots, well, I might immediately ask back, which studies show that and what formulations were used in those studies? Usually those risks trace back to conjugated equine estrogen or synthetic progestins and not estradiol with progesterone. The same with things like osteoporosis research. Open evidence may conclude estradiol isn't first-line therapy for osteoporosis, but when you look closely, the guidance comes from WHI-era CEE and medroxyprogesterone studies. The lesson is not just to read the summary, but interrogate it. Ask for citations, check formulations, decide if those outcomes match what you're doing in your practice. The other way to get better results from open evidence is to ask better questions at the outset. If you ask something like best treatment for osteoporosis prevention in postmenopausal women, you'll get bisphosphonates and so on. But if you ask, how does estradiol replacement influence bone density and osteoclast activity in early postmenopause, you might get physiology and mechanism and not just drugs like bisphosphonates. The more specific and physiology-based your prompt is, the more relevant your results might be. You're essentially sort of teaching open evidence to think like a hormone optimization provider. So here's the takeaway. Open evidence gives you AI-level efficiency with PubMed-level credibility. No hallucinations, no imaginary citations, just verified research that's organized for real-world use. But that accuracy isn't the same as neutrality. The literature itself carries bias, and open evidence does reflect that bias. Our role as clinicians is to interpret the data through the lens of physiology and prevention and what we know of the literature. AI can summarize data, but only you can synthesize wisdom. If this kind of discussion about open evidence and evidence-based hormone optimization helps your medical practice, let's stay connected. Visit simplehormones.com/database to learn more about my hormone provider database. That's the directory where I send hormone-focused patients to qualified providers just like you. It's a great way to connect with the right patients, but also to access some tools that can strengthen your hormone practice. While you're here, be sure to subscribe to the channel for more videos on hormone research, functional medicine, patient communication. Thanks so much for watching. I'm Steve Goldring, the Hormone Pharmacist. I'm here to help. We'll see you in the next one.